Hello, my name is Allison Herschede, and today I want to talk to you about low carb type 1 diabetes and pregnancy. The objective of today's talk is to outline the risk associated with type 1 diabetes and pregnancy, but not only that, to explain the root cause of these risks and to describe how we can mitigate those risks through therapeutic carbohydrate restriction and precise insulin titration. Before we start, I'd like to give a disclaimer that any statements made in this video should not be construed as medical advice. They are for informational purposes only, and any changes to your diet or diabetes management should be discussed with your doctor or other healthcare provider. So just to give you a little background, I have been living with type 1 diabetes for 42 years. I was diagnosed with type 1 diabetes in 1981 at the age of 18 months. And at the time of my diagnosis, my parents were warned that I should never become pregnant. They were told that their risk was incredibly high, that it was likely that if I became pregnant, my baby would be stillborn, or if by some chance I was to deliver a living baby, it would probably have birth defects or be very large, and that I would likely be hospitalized for months of my pregnancy. Well, thanks to modern medicine and more modern insulins and technology, I was able to have 3 successful pregnancies. My first 2 pregnancies were successful pregnancies. I had healthy babies that were full term, but I was using a lot of injected insulin, and I experienced many episodes of severe hypoglycemia due to the large doses of insulin when I was following the standard American diet. My very last pregnancy, my 3rd baby, I was following a low carb diet. I started eating low carb in 2010. And by eating low carb, I was able to lose about 55 pounds. I was able to come off 15 prescription medications that I was taking at the age of 30. And after about 4 years, I started following Dr. Richard Bernstein's protocols. It allowed me to normalize my blood sugars. And for the last 10 years, I've been running in the non-diabetic range. So this last baby, I was following a low carb diet, and I cannot tell you the difference between this pregnancy and my previous pregnancies. This one was so much smoother. I had much fewer highs and lows, and I was even able to give birth via vaginal birth after 2 cesarean sections. My first 2 babies had been taken via scheduled cesarean at 38 weeks, just due to the risk of type 1 in pregnancy. And by the time my 3rd baby came around, I had done my research, and I had decided that my risk was pretty close to that of a non-diabetic because of my type 2 control. I've also been leading type 1 diabetes and pregnancy groups since 2006. I'm a registered nurse, a certified diabetes care and education specialist, and I've written a book called Grit Pregnancies: How to Help Healthy Pregnancy and Normal Blood Sugars with Type 1 Diabetes. So just to review, what is type 1 diabetes? Well, you've probably heard of type 2 diabetes, which is the most common form. Type 1 is an autoimmune condition in which the immune system attacks the insulin-producing beta cells in the pancreas. And insulin is required for life. We need insulin for glucose or energy to be transported into the cells of the body. And if untreated, type 1 diabetes will ultimately lead to common death. A type 1 diabetic has to inject insulin every day for the rest of their life, and they need to maintain normal non-diabetic blood sugars if they want to avoid the complications of diabetes. So what are the risks of type 1 in pregnancy? Well, there are quite a few. In pregnancy with type 1, the patient is at risk for miscarriage, first of all. They're also at risk for birth defects, for complications such as preeclampsia, progression of diabetic retinopathy, or chronic kidney disease. They're also at risk for macrosomia, which is when your baby is too large for their gestational age. For IUGR, intrauterine growth restriction, polyhydramnios, which is too much amniotic fluid, neonatal hypoglycemia or low blood sugar, respiratory distress syndrome, jaundice, placental failure, and at worst case, stillbirth. So what's the cause of all these complications? What is the cause of all these risks? I've stated this so many times. Diabetes is just a word. High blood sugars are what cause the risk of complications in diabetes. So what is the risk of miscarriage? Why is there a risk of miscarriage? Well, First of all, it's pretty common for pregnancies to end in miscarriage. 1 in 4 pregnancies may end in miscarriage, but this is much more common in type 1s. Miscarriage is defined as a loss of pregnancy before 20 weeks gestation, and in type 1, it's usually due to genetic anomalies. High fasting glucose is strongly correlated to the levels of maternal hormones that are necessary to sustain a pregnancy. So why the genetic anomalies? Well, the organs of your baby are developing in the first 10 weeks of pregnancy. And if your blood sugars are not in good control during those first 10 weeks, birth defects are more likely. According to Sugar and Durat in 2018, elevated blood glucose levels at conception and during the early first trimester is associated with increased rates of congenital malformation of the central nervous system, cardiac, gastrointestinal, and genitourinary tract, and is significantly more incident with an A1C greater than 7%. And the risk is proportional to A1C. Preeclampsia is also very common in type 1 diabetes. So preeclampsia happens only during pregnancy, and symptoms include edema or swelling of the face or extremities, elevated blood pressure, headache, visual disturbance, and protein in the urine. And preeclampsia can be very dangerous because untreated, it can lead to eclampsia or toxemia, which affects the brain and can cause seizures, and ultimately it can cause death. So according to Becker in 2017, impaired vascular reactivity in pregnant women with T1DM makes them more susceptible to develop preeclampsia. And the risk of preeclampsia increased significantly with increasing A1C values above optimal levels. Excuse me, the first quote was Kolsresha and Arbwal in 2016. So there are other theories as to what causes preeclampsia, and I'm sure some of them are definitely relevant, such as there's a theory that the autoimmune response can cause preeclampsia, or that if parents have different blood types, this could cause a reaction with the placenta and cause preeclampsia. But ultimately, we know the highest risk for preeclampsia and type 1 diabetes is hyperglycemia. So if there are already pre-existing diabetic complications, they can progress during pregnancy. So what causes diabetic retinopathy? Well, high blood sugars cause the pericytes in the retina. They cause the retina basically to become leaky, to hemorrhage. And this will eventually lead to visual impairment and ultimately blindness. 50 to 70% of cases will progress during pregnancy. So according to Wyckoff and Brown, worse metabolic control at conception predicts a higher rate of progression of diabetic retinopathy. Interestingly, however, a greater magnitude of improvement in glycemic control during pregnancy has been correlated with a higher risk of diabetic retinopathy progression. Therefore, ideally, female diabetics of childbearing age should achieve normal glycemia, which they define as a hemoglobin A1C of less than 7%, but we'll talk a little bit more about that later. But we do know that if pre-existing proliferative retinopathy exists, rapidly controlling blood sugars can cause a temporary progression of the diabetic retinopathy. So ultimately, we really want to prevent this beforehand. We want to get blood sugars under control prior to conception. The progression of chronic kidney disease, again, chronic kidney disease is caused by high blood sugars. AGEs, or advanced glycation end products, caused by hyperglycemia, cause damage to the blood vessels in the kidney, and may damage the nephrons, which allows larger proteins, which should not get through the kidney, to pass through, and this damages the kidney further. So due to the increased load, increased blood volume during pregnancy, we see progression of chronic kidney disease to the already weakened kidney function. Macrosomia is one of the most common complications we see in type 1 pregnancy. Macrosomia is defined as having an infant that weighs greater than 4,000 grams or 8 pounds and 13 ounces. Macrosomia can cause a number of complications, such as shoulder dystocia, brachial plexus injury, injury to mom, her vagina and perineum can be damaged, uterine rupture, postpartum hemorrhage, even possibly brain damage to the infant. So labor is routinely induced around 37 to 38 weeks in type 1s due to the risk of macrosomia, also due to the risk of placental failure and stillbirth. Often we see cesarean sections in type 1s due to the risk of macrosomia or suspected macrosomia. And we know that suspected macrosomia due to estimated fetal weight via ultrasound is very inaccurate. So, in my opinion, a lot of cesarean sections happen unnecessarily due to the suspected risk of macrosomia. So if we can avoid macrosomia, this is going to be quite beneficial. But what causes macrosomia? So when mom's blood sugar is high, this causes baby's blood sugar to be high. And baby has its own pancreas and it's making its own insulin. So it makes increased insulin to bring down that high blood sugar. And we know that insulin is a fat storing hormone. So with hyperinsulinemia, the fetus is making increased insulin, therefore it's gaining weight due to that increased insulin. So we're going to see these cute little babies with cherub cheeks, but this is not a good thing. This is harmful. It can cause injury, and macrosomia is one of the greatest risks in type 1 pregnancy. According to Dr. Lois Jovanovich-Peterson, who is a pioneer in type 1 diabetes and pregnancy, she said a first trimester non-fasting blood glucose level greater than 120 milligrams per deciliter, which is 6.7 millimoles per liter, increases the risk of macrosomia by 24%. So really keeping those blood sugars normal is imperative. IUGR, or intrauterine growth restriction, typically occurs due to placental dysfunction. And this is placental degradation or calcification due to maternal hyperglycemia. This induces thickening of the basement membrane, which reduces oxygen transport. Increased levels of placental leptin also contribute as well, and maternal and fetal hyperinsulinemia. So there's a lot of factors involved with IUGR and placental failure, but ultimately the underlying cause is hyperglycemia. So type 1 moms are typically recommended to start low-dose aspirin around 12 weeks of pregnancy to help prevent placental failure. So polyhydramnios is excess amniotic fluid. It happens typically in 1 to 2% of pregnancies, but it happens more in type 1 pregnancies. So why do type 1s have a higher risk of having too much amniotic fluid? Well, again, when mom's blood sugar is high, this raises your baby's blood sugar. And when baby has high blood sugar, it has the same symptoms as anyone else would with high blood sugar. They start urinating more to rid their body of the excess glucose. And this excess urine causes excess amniotic fluid. Also, a larger fetus is going to make more urine than a smaller one. So with polyhydramnios, there's increased risk of malposition. So we might see a breech baby or a transverse baby, or we might see an umbilical cord prolapse. All of these things are dangerous and can lead, clarify, umbilical cord prolapse is very dangerous. A malpositioned baby is probably just going to require a cesarean section. So some doctors will drain the amniotic fluid to lower it for mom's comfort, but that's not without risk because, we're inserting a very long needle into the uterus. So again, if we can prevent this, that's the ultimate goal. Respiratory distress syndrome is also commonly seen in babies of type 1 diabetic mothers. Due to high blood sugars in mom, the synthesis of surfactant is delayed. So what is surfactant? Surfactant is a substance which makes the lung tissue more elastic, increases the surface area, and it keeps the alveoli in the lungs from collapsing. It's also thought to be due to fetal hyperinsulinemia, too much insulin in the fetus, which can interfere with the lung development from glucocorticoids. So these babies are typically they're going to have NICU time. They might have to be on a ventilator or on oxygen. So honestly, in my opinion, taking a diabetic pregnancy early is a higher risk of respiratory distress syndrome, but that's a whole nother story. Jaundice is something we also commonly see. When we see maternal hyperglycemia and subsequent fetal hyperglycemia, the fetal hyperinsulinemia increases the fetus's metabolism. So they're consuming more oxygen. And due to this, relative hypoxemia, they're producing more erythropoietin. So erythropoietin is a hormone produced by the kidneys, and it causes more red blood cells to be produced to carry that excess, the oxygen that's needed. Well, the breakdown of those red blood cells after the baby is delivered results in high levels of bilirubin, which can cause jaundice or a yellowing of the skin and eyes. And these babies probably will spend a little time in the NICU, and they'll have to spend some time under a special light or a special blanket to lower their levels of bilirubin. Neonatal hypoglycemia. So this is low blood sugar. You might wonder why is a baby going to have low blood sugar when mom has high blood sugar? Well, when mom's blood sugar is high again, the baby's blood sugar is elevated. So the baby's going to try and bring down that sugar with its own insulin. So it's making increased insulin. So when the infant is delivered and the umbilical cord is severed after delivery, that constant source of glucose is abruptly cut off. But that baby is still making excess insulin. So baby's blood sugar is going to tank. So these babies are going to spend time in the NICU, probably. They're going to, if it's a mild case, they might be able to have some formula or some liquid dextrose. Or some moms, some type 1 moms, will start collecting their colostrum and in syringes and bring it to the hospital in case baby has hypoglycemia. But if the blood sugars are not coming up, then the infant is probably going to have IV dextrose. My second baby actually had hypoglycemia because they let my blood sugar run high before the delivery because they made me remove my insulin pump, which was a horrible thing. Some studies suggest that if mom's blood sugar is higher than 110 milligrams per deciliter or 6.1 millimoles per liter at the time of delivery, there's an increased risk of hypoglycemia in the infant. So this is the absolute worst complication. This is what's looming in every type 1 mom's mind, possibility of stillbirth. So stillbirth is when a pregnancy is lost after 20 weeks of gestation or beyond. So in years past, diabetes meant a very high risk of stillbirth. And today, with our modern insulins, our insulin pumps, and our CGMs, the risk is much lower. It's close to that of a non-diabetic mother, but there are still studies that show there's an increased risk, even with tight control. You'll have doctors who tell you it doesn't matter. Even with tight control, there's risk. Well, why would that be? The problem comes down to their definition of tight control. They're calling tight control an HbA1c of less than 6.9%. An A1C of 6.9% averages approximately 168 milligrams per deciliter, or 9.4 millimoles per liter. And this is nearly double the blood sugar of a healthy non-diabetic. So this is not tight control. We know that incidence of stillbirth increases with increased HbA1c. And while we don't know the reason for every case of stillbirth, some of them just happen. Many are due to placental dysfunction or failure or from congenital anomalies, all of which are caused by hyperglycemia. So what are the targets for type 1 diabetic pregnancy blood sugars? Well, according to the American Diabetes Association, they like to keep type 1 pregnant women in a time in range for pregnancy. The common time in range that we hear about for diabetics is 70 to 180 milligrams per deciliter, or 3.9 to 10 millimoles per liter. And 180 milligrams per deciliter is very high, and it's going to lead to problems. And in a pregnancy, we know this is much too high, so they've lowered that upper limit to 140 milligrams per deciliter, which is still, in my opinion, too high, but it's definitely better. The goals are greater than 70% time of blood sugar readings within the range of 63 to 140 milligrams per deciliter. So the low end is a bit lower because non-diabetic pregnant women tend to run in the 60s, probably due to the increased blood volume, plus the fact that the fetus is taking more glucose from mom. It's normal for non-diabetic moms to run in the 60s. Therefore, the targets for diabetic moms are 63 to 140. We want less than 4% of readings to be less than 63, less than 1% of those readings to be less than 54, and less and 25% readings to be greater than 140 milligrams per deciliter. This is a list of the various targets by organization of listing ADA, ACOG, NICE, Canada, Australia, and IDF. They're all pretty similar. They all have pretty similar ranges, some as low as 60, some higher in the 70s, but almost all of them want blood sugar to be less than 140 in an hour and less than 120 at 2 hours. As of note, as of 2023, the American Diabetes Association is now targeting a fasting blood glucose of 70 to 95 milligrams per deciliter, though their timing range is still the same. So how do we do this? How do we normalize blood sugars in a type 1 diabetic? How do we meet these goals? So this overview here, this is a Dexcom overview, and this is from one of my pregnant clients who's doing a great job. And you can see her average blood glucose is 95 milligrams per deciliter. She has a really good standard deviation of 21 milligrams per deciliter. What standard deviation tells me is how much a person is going up and down. And I personally target around 20 milligrams per deciliter, 1.1 millimoles per liter for my standard deviation. You can see that she's 94% time in pregnancy range. She's 4% high, and she's less than 1% low. So how did she do that? Well, first of all, we restrict carbohydrate. We restrict them to fibrous vegetables, nuts, seeds, dairy, and berries if they tolerate them. Some people do not tolerate dairy, and some people cannot tolerate berries. It spikes their blood sugar, but some people can. We're avoiding grains, sugar, starch, and sweet fruits. So the focus of our caloric intake is mainly protein and fat. So the first part is to get the food under control. We're limiting our carbohydrates. The second part is our insulin. So we want to test our basal insulin in the fasting state. We want to test our glucose and our insulin sensitivity. And we also want to implement the use of regular insulin or extended boluses to cover protein. If you are a type 1 diabetic, or if you're a medical professional who works in the type 1 field, you've probably been taught that protein is free and protein does not require a bolus. Well, I'm here to tell you that's wrong. Anyone who is following a low carbohydrate diet and who has a continuous glucose monitor, they can see the rise from protein, usually about 1 to 2 hours after their meal. So they might bolus perfectly for their carbohydrate, but then about an hour or two later, you start to see a rise from that protein. Well, here's why. When protein is taken in and the amino acids are taken up, there is a release of glucagon. And in a healthy non-diabetic, there's a release of insulin. And these two effectively cancel each other out, and there's no effect on blood sugar. But in a type 1 diabetic who makes no insulin or not enough insulin, we have the glucagon response, but we don't have the insulin response. Therefore, we see a rise. So ultimately, we need to cover protein with insulin. Dr. Richard Bernstein recommends using our insulin, which is also known as Act Rapid or Humulin S in some other countries. This insulin has a slower onset, it has a longer duration, and it's gentler. It's a less potent insulin. So in my opinion, it's actually safer. Many doctors do not use R. They are not trained in R. They've been trained to believe that R is an outdated insulin and that it's inferior, when in fact, it is perfect for the low-carb, high-protein profile. So if we can use R, this is wonderful. If we can't use R, that's still okay. What we can do is we can use an extended bolus on an insulin pump to mimic the action of R, or we can take a second dose of rapid-acting insulin. But this really can be done multiple ways. We want to correct highs and lows precisely to target. And we also want to use a continuous glucose monitor if at all possible. A CGM is an absolute necessity for pregnancy, in my opinion. This is a quote from Dr. Richard Bernstein. Dr. Bernstein was diagnosed with type 1 diabetes in 1946 at the age of 12. So he's been type 1 for 75 plus years. And he's been eating low carb for 50 of those years, 50 plus years. He was able to reverse his diabetic complications such as stage 3 kidney disease and gastroparesis, as well as many others. And he's still practicing medicine today at the age of 89 years old, and he's still in great shape. So this quote from Dr. Bernstein is diabetics are entitled to the same normal blood sugars as diabetics, non-diabetics. So this is my tenet. This is my belief. I deserve the same normal blood sugars as a non-diabetic, and so does every other diabetic. So I highly encourage reading Dr. Bernstein's Diabetes Solution. This book is the Diabetes Bible. It's a very thick book, but it is well worth your time. It is a game changer. So the standard recommendations for diet in type 1 pregnancy is usually 3 meals and 2 to 5 snacks every day. Those meals are recommended to be around 45 to 60 grams of carbohydrate per meal and 15 to 30 grams per snack. It's recommended to have at least a minimum of 175 grams of carbohydrate. And it's recommended to count your carbs and to use an insulin to carb ratio to cover those carbohydrates. And in theory, this is great. This is a wonderful idea. If we can precisely count our carbohydrate grams and cover it with the proper amount of rapid-acting insulin, there should be no rise in blood sugar. But that's a great theory. In practice, it doesn't work. Again, if you have a continuous glucose monitor, you can see that it doesn't work. So 175 grams of carbohydrate is going to be difficult, if not impossible, to maintain normal blood sugars. So why low carb? Well, diabetes is a condition of carbohydrate intolerance. Ultimately, it's carbohydrate intolerance. And if I was intolerant to a food, so say I'm lactose intolerant, is someone going to offer me ice cream or cheese or say, Allison, you should be drinking all this milk? No, they're not. They're going to say, she's lactose intolerant, don't put the cheese on her pizza. Or if I had a peanut allergy, would I be encouraged to go eat peanut butter and just to use my EpiPen? No, I would not. People with food allergies, people with food intolerances, they're to avoid the food they're intolerant to. We don't properly metabolize carbohydrate yet. We're encouraged to focus our diet on grains and starches. So this little graphic was made by my friend Artie Deitman, and it makes perfect sense in my opinion. It says, if I can't metabolize this, which is a glucose molecule, why should I eat this? And it shows a complex carbohydrate molecule, which is chains of glucose. So carbohydrates are a non-essential macronutrient. If we don't eat amino acids, if we don't eat fatty acids, we're going to die. Those are essential macronutrients. Carbohydrates, not an essential macronutrient. One of the major tenets of Dr. Bernstein's diabetes solution is the law of small numbers. The law of small numbers says big inputs make big mistakes and small inputs make small mistakes. We know that large amounts of carbohydrate and large amounts of insulin are unpredictable. Therefore, if I'm going to the pizza buffet and I'm taking 25 units, which I used to do, this could end very badly. I could go very high, I could go very low, and some days I may perfectly nail it and I'm going to say, I can eat pizza. I have no problem with pizza. I got it perfectly. And then the very next time I try it, I might go high or low again because carbohydrate and insulin are unpredictable. We're trying to match two sharp peaks, and that's nearly impossible. This little graphic is absolute truth. It says bread is sugar, rice is sugar, pasta is sugar, fruit is sugar, and cereal is sugar. All of these things are the truth. Due to an enzyme called salivary amylase in your saliva, carbohydrates starches are rapidly broken down into glucose while they're still in your mouth. We're told, oh, complex carbohydrates are going to cause a slow rise now. When you start chewing that bread in your mouth, it is immediately turning to glucose. And a few years ago, Dr. Bernstein did an interview that was recorded, you can find it on YouTube, in which he started chewing a piece of bread. He spit on a glucose testing strip for urine glucose. They're called diastics. It immediately turned black because that bread was immediately turning to glucose. Grain, sugar, starch, and sweet fruit are rapidly broken down into glucose and they rapidly raise blood glucose levels. So why are diabetics being told to eat them? That's the list of ingredients that can rapidly raise blood sugars or just raise blood sugars in general. It should say not blood sugar friendly, though I'm not sure if you can see that or not. Hopefully these slides will be available to everyone. I use this with my clients. So wheat, rice, oat, flour, cornstarch, modified food starch, all these things listed can raise blood sugar. So I avoid anything on this list, except possibly xylitol if it's eaten in very small amounts. But xylitol is actually toxic to animals, so keep that in mind. I don't count carbs. I look at ingredients. So for instance, if something contained sorbitol, even if it claimed 3 grams of carbohydrate on the label, I know it's going to raise my blood sugar. So I look at labels. I look at ingredients. If something has one of these ingredients, I'm not going to eat it. You might be asking yourself at this point, well, if we're avoiding all these things, what is left to eat? So I'm telling you, there's plenty left to eat, and I really enjoy my food. So what's left to eat? Protein. We're looking at all forms of animal protein, so meat, chicken, fish, eggs, dairy if you tolerate it, nuts and seeds, fibrous vegetables, and maybe some berries, and an occasional low-carb treat made with almond flour if you tolerate it. So these are some lists of some blood sugar-friendly foods that I use with my clients. You can see there's protein and vegetables. Those are the basis of the diets, protein and vegetables. And then I have some other products, ready-made products that are available here in the US that you can also use that are safe on blood sugars. So doctors in the audience, OBGYNs, may be asking themselves, are these caloric needs being met if my patient is following a low-carb diet? Well, during the first trimester, there's no recommended change in caloric needs. We're not really eating for 2. We're never actually eating for 2. During the second trimester, 200 to 400 more calories are recommended. And during the third trimester, there's an additional 400 calories a day recommended. So 500 calories sounds like a lot, or 400 calories sounds like a lot, but it's really not. It's really easy to eat 400 calories. So if you've ever noticed those packs of mixed nuts in the checkout aisle, they have about 500 calories in them. And I learned this the hard way because I gained 15 pounds and couldn't figure out why. And I realized, well, I've been eating a pack of mixed nuts every day. That's an additional 500 calories. So package of mixed nuts is 500 calories. 2 ounces of cheese is 200 calories. 3 hard-boiled eggs, 234 calories. 3 tablespoons of peanut butter, 282 calories. And it's really, really easy to overeat peanut butter. It's really easy to overeat all of these high-protein, high-fat foods. So it's not difficult to get adequate calories on this diet. The next question may be, are the nutritional needs being met? So in my opinion, if this is done right, a low-carb diet is actually more nutritionally dense than a standard American diet. So this list tells you how you can obtain all the vitamins and nutrients that are needed on a low-carb diet. Any nutrient that you can get on a high-carb diet, there's a low-carb alternative. You can see there's many options here. Something of note, there was a study a couple years ago that showed an increased risk of neural tube defects in babies of moms who are following a low-carb diet due to low intake of folate. So folate is very important, and we really want to emphasize folate-rich foods, which are listed in these slides. And this is not a time for lazy keto. This is not a time for dirty keto. We do not want to just be eating bacon cheeseburger and cheese. We want to be focusing on our nutrient-dense vegetables as well. Or if we don't eat vegetables, have some organ meats. Liver is one of the most nutrient-dense foods there are. Also, egg yolks are very nutrient-dense. We also recommend a high-quality prenatal vitamin just to kind of cover our bases. And I do recommend activated folate rather than folic acid because a large percentage of type 1 diabetics actually are positive for the methyl tetrahydrofolate or MTHFR mutations, which cause problems with metabolizing B vitamins and folate. So if you don't know your MTHFR status, just take activated folate, also known as methylfolate. Something very important of note, if carbohydrates are lowered, we need to reduce injected insulin. I personally reduced my insulin by 50%. So very, very important. If you have a patient who is starting on a low carbohydrate diet and they're on fixed doses of insulin, they need to reduce those doses of insulin. I may take a half unit for a meal. At the very, very most ever, I might take 3 units. typically I'm taking half a unit to a unit per meal. So this is dramatically lower than most meals that a type 1 would eat on a standard American diet. Here's another big question. Doesn't the baby need carbohydrates to grow and develop? This was a huge concern of my endocrinologist during my pregnancy. He insisted I needed at least 100 grams of carbohydrate. He was begging me, please increase your carbohydrates. Your baby needs carbs to grow. Well, he wasn't a bad guy. He was just misinformed. Baby doesn't need carbs to grow. Baby needs glucose to grow. And there's plenty of that going around, I promise you. The body is making all the glucose that is needed via a process called hepatic gluconeogenesis. And if you're a type 1 diabetic who's ever missed your basal shot, or if you're using an insulin pump and you've ever had a cannula, you know how rapidly your blood glucose increases, even if you aren't eating anything. If I were to stop insulin right now, my blood sugar would rise to dramatically high numbers and I would ultimately die, even if I ate nothing. This is because my body is making sugar 24 hours a day. According to the Institute of Medicine, the lower limit of dietary carbohydrate compatible with life is apparently 0, provided that adequate amounts of protein and fat are consumed. So you might have been told, what you eat goes to the baby. When I eat a piece of bread or a cookie, that's not going to the baby. The baby's getting glucose from my bloodstream. The baby's getting nutrients from my bloodstream, but it's not getting carbs. It's getting the glucose that's in my bloodstream. So if there is adequate glucose in my bloodstream, i.e. a normal blood sugar, I think we can deduce that the fetus is getting glucose through the umbilical cord from mom's bloodstream. There's no carbohydrate required. Glucose is what is required. Big question. This is the next one that all the doctors harp on. Oh, ketones. No, ketones are dangerous. So if you've ever had a patient diagnosed with type 1, they were probably in a state of diabetic ketoacidosis, which is a life-threatening condition. Diabetic ketoacidosis is due to insulin deficiency. The ketones themselves are not the problem. The insulin deficiency is the problem. The insulin keeps the ketones from spiraling out of control. And we know that pregnancy is a ketosis-prone state. Non-diabetic moms, especially if they have morning sickness, they're going to have ketones in their blood and in their urine. And I do recommend a blood ketone meter rather than urine. Infants who are born, all infants are born, when an infant is born, they have ketones in their umbilical cord blood. There are ketones in the placenta. Breastfed babies are in ketosis for at least the first month of life. And, fun fact, ketones are necessary for brain development and fuel. So this quote is by Lily Nichols, and she is a registered dietitian in CDCEF. She's written an amazing book called Real Food for Gestational Diabetes. I highly recommend it if you have gestational diabetic patients. She says that ketones provide essential cerebral lipids for fetal brain development and supply approximately 30% of fetal brain energy needs. Babies are born in ketosis, and they remain in ketosis for at least the first month of life in breastfed infants. Ketones present at low physiological levels in pregnancy do not pose harm to the fetal brain development. Rather, they appear to be vital to healthy brain development. And according to the Institute of Medicine, as part of the adaptation of pregnancy, there's a decrease in maternal blood glucose concentration, a development of insulin resistance, and a tendency to develop ketosis. So again, we're seeing ketones in pregnancy. This is super normal. The problem comes in when we have an insulin deficiency. So what's the difference? DKA versus nutritional ketosis. Most doctors actually learned about this back in biochemistry, but they've probably forgotten it. DKA, life-threatening state, caused by a lack of insulin. When we see DKA, it's typically with a blood sugar, high blood sugar, above 250 milligrams per deciliter, though this isn't always true. We're going to see an anion gap of less than 10. We're going to see ketones greater than 3 millimoles per liter, though typically, in the cases I've personally seen, they're almost always above 10 millimoles per liter. They're very high. The arterial blood pH is going to be less than 7.3. The bicarbonate level is going to be 18 milliequivalents per liter or less. Symptoms include fruity breath, vomiting, and Kussmaul breathing. Kussmaul breathing is this where you're trying to get in more oxygen versus nutritional ketosis. Ketosis is a healthy, natural state that's a result of a low-carb diet or a result of burned fat. Blood glucose is normal. The anion gap is going to be normal. It's going to be greater than 10 ketones. Optimally for nutritional ketosis are around 1 to 3 millimoles per liter. This is what the people on a ketogenic diet are striving for. Their arterial blood pH is normal at 7.38 to 7.42. Bicarbonate levels, 22 to 28 MEQs per liter. And you may be seeing the fruity breath, but they're not going to experience the ill effects that you see in decay. They're not going to have the nausea, the vomiting, the cramping, the post-mortem breathing. You're not going to see any of that because it's a healthy state. So you might be jumping to the thought, well, what about euglycemic ketoacidosis? Everybody's heard about EDKA because of the use of a medication class known as SGLT2 inhibitors. So SGLT2 inhibitors cause a diabetic to urinate out glucose at a lower level, lower threshold. The renal threshold is typically around 180 milligrams per deciliter. At that point, a person's going to start losing glucose through their urine. These medications lower that threshold and cause more glucose to be lost through the urine. So we have normal blood sugars, but we're lacking insulin. Therefore, in my opinion, a type 1 should not be taking an SGLT2 and most definitely not a pregnant diabetic. These medications are contraindicated in pregnancy. But we can see DKA at normal blood sugars due to the insulin deficiency on an SGLT2. Because the SGLT2 has normalized the blood sugar without insulin, we have insulin deficiency. So in the absence of SGLT2 inhibitors, EDKA is exceedingly rare. It is very rare. A lot of the patients who've gone in and been diagnosed with EDKA were not actually in DKA. There were no arterial blood gases drawn. The doctor was basing the diagnosis based only on the presence of ketones. So true EDKA, every case that I've seen, and very few cases I've seen, I can count on one hand, every single case was a result of prolonged fasting and dehydrating illness. So I do not recommend prolonged fasting for a type 1 ever. I know some people do it, and some people will tell you it's perfectly safe, and there's a famous doctor out there who's done it safely, but he was monitored. Don't recommend it in pregnancy. We don't want to be fasting for a long period of time because this depletes the glycogen stores. We have no stored glucose. Therefore, the insulin needs are lowered. So a type 1 is going to start seeing tons of low blood sugars, and they're going to decrease their insulin. But this lack of insulin is allowing those ketones to start spiraling out of control. And as those ketones get higher and higher, if you add dehydrating illness to that, this compounds the effects, and you can see DKA at normal blood sugar levels. So do not recommend prolonged fasting. And that's all I can say there. So I've harped all this time about ketones, but I want to tell you, Dr. Bernstein's meal plan is not a ketogenic diet. And he will flat out tell you this is not a ketogenic diet, and he does not recommend a ketogenic diet. He's recommending a low-carb, high-protein diet. He's not recommending you add fat, and I don't add fat. And if you were to test my blood ketones right now, and I do recommend, again, a blood ketone meter because urine ketones are not accurate. If I tested my ketones right now, it would probably be around 0.2 millimoles per liter or less. I don't have ketones. It's very rare that I see ketones. And if I do, it's probably because my insulin pump is failed. So if we're seeing ketones in pregnancy, it's probably due to the pregnancy. Or I should state, if we're looking at severe morning sickness or hyperemesis gravidarum, these moms definitely will want to go into the emergency room for fluids because that could lead to decay. That is a case that could lead to decay because they're going to be fasting due to all the vomiting. I had one person I know of who had EDKA during pregnancy due to hyperemesis gravidarum. She had fasted for over a week. Point, Bernstein's plan is not a ketogenic diet. So shifting over from food to insulin. Food is a very big part. It's one of the factors, it's one of the variables that we can control. We can't control a lot of the variables. We can control food. So the second part of this equation is insulin. So this graph depicts the typical insulin need changes that we see during pregnancy. If you're a type 1 woman who has ever been pregnant, this is probably what you saw. You probably saw high blood sugars at the very beginning. This was my first symptom with all three babies. I initially saw a rise in blood sugars, honestly, right after conception. And definitely before I even missed a period, I was seeing high blood sugars. So you're seeing increased insulin needs from 4 to 5 weeks or even earlier. Then you're seeing a precipitous drop in insulin needs, usually around 6 to 10 weeks. I call that the period of the lows. Insulin needs are decreased below pre-pregnancy levels. They start climbing usually around 18 weeks, definitely after 15 weeks. And we really see a peak in insulin needs around 22 to 28 weeks. And this is when women are tested for gestational diabetes because the placenta is making hormone, human placental lactogen, which causes insulin resistance, so baby can get more glucose. So this is really when we see the insulin needs ramp up. They're going to continue climbing until around 34 to 36 weeks. And this is really something I want to make a note of. I made a whole chapter on this in my book. Around 34 to 36 weeks, I typically see a drop in insulin needs in type 1s. And when the obstetrician or maternal fetal medicine doctor sees this drop in insulin needs, they panic. They say, oh, the placenta is failing. And I can't tell you how many moms that I have seen induced early or who had an emergency cesarean section due to placental failure that was only based on decreased insulin needs. This is so incredibly normal. I had this with all three of my babies, and thankfully my doctors were aware that it was normal. Now, can placental failure happen? Absolutely. And would a drop in insulin needs indicate placenta failure? Yes. So how do we know? We can check the placenta. We can do an ultrasound. We can look for premature aging of the placenta. We can look for calcifications. We can look at the blood flow to and from the placenta. Are we seeing reverse blood flow? If we're seeing reverse blood flow, yeah, we have a problem. We need to deliver that baby ASAP. We can monitor the baby. We can do non-stress tests and biophysical profiles. But inducing labor based only on decreased insulin needs, in my opinion, a huge mistake because this is so incredibly normal. So beyond that, some women will not see this drop and insulin needs will continue rising until delivery. And then typically we see a precipitous drop in insulin needs after the placenta is delivered, or in some cases the next day, back to below pre-pregnancy levels. So the three things we focus on are testing basal insulin. We want to test what basal insulin is doing. Is it keeping blood sugar flat in the fasting state? We don't want basal to bring blood sugar down to normal. We want it to keep blood sugar normal. We would use rapid to bring it down to normal. So in the fasting state, blood sugar should stay within probably a 15, maybe 30 milligram per deciliter max change in blood sugar level. So we want to stay flat as we can. I don't want prolonged fasting in a type 1 pregnant woman, as I said previously. So what we'll do is we'll maybe have an early breakfast one day and a late lunch. And then another day we'll have a late breakfast and we'll skip lunch and have an early dinner. And then another day we'll have an early dinner and then we'll go to bed early. And we'll see what blood sugar does every night. So during those blocks of time, we can see if basal is holding blood sugar steady in a fasting state. Second, we want to test the effects of 1 unit of rapid-acting insulin rather than using any formula to calculate based on total daily dose. This does not work in low carbers. We want to actually test how much 1 unit lowers blood sugar. And then we want to test how much does 1 gram of glucose raise blood sugar. So I personally know from testing, my basal is good. 1 unit drops me 85 milligrams per deciliter, and 1 gram of glucose raises me 5 milligrams per deciliter. So I know how to precisely treat highs and lows to my target of 83 milligrams per deciliter. So insulin needs in pregnancy change, and they change rapidly, and they change frequently. So this is something we have to keep on top of. During my first pregnancy, I had a CDE helping me. She would call me in the second and third trimester. She was calling me every 2 days to change my insulin doses because that's how rapidly they were changing. So working with the CDCES can be incredibly helpful. And just a note, I do pregnancy coaching. So what about lows? What about hypoglycemia? In a non-pregnant person, hypoglycemia is defined as less than 70 milligrams per deciliter. In a pregnant person, we're looking at less than 63 milligrams per deciliter, or 3.5 millimoles per liter. We want to only use glucose to treat hypoglycemia. We don't want to treat with food. Food is unpredictable. food is likely going to end up causing a high blood sugar later. I want measurable, predictable results, and that's glucose. So we can use liquid glucose, which is honestly my favorite. This is my preferred method because it's faster than all the other forms. I personally use glucose tolerance test liquid, which is much more affordable than liquid glucose available at the pharmacy. I put it into little 1-ounce bottles of 5 grams each. I know 5 grams is going to raise me 25 milligrams per deciliter. So if I'm at 70, it's going to raise me to 95. You can use liquid. You can use powder. You can use dextrose-based candies. That's really popular here in the United States in the low-carb community. We have candies called Smarties. These are not the chocolate candies that other people are familiar with. These are dextrose-based. They're called Rockets. They're also called Fizzers in the UK and Australia. You can use dextrose-based candies. You can use glucose gummies. Those are also fun. You can use glucose gel. There's many different forms of glucose. They all work the same, though liquid is faster. So we want to treat with glucose only, and we want to treat to target. We don't want to overtreat. The rule of 15 is almost definitely going to cause high blood sugar, especially in pregnancy, because you become very carbohydrate sensitive in pregnancy. So the rule of 15 does not apply here. We want to find out how much 1 gram raises blood sugar and use that formula to treat precisely to target. The same thing goes for high blood sugars. We want to treat high blood sugars to target. I know exactly how much insulin I need to treat a 120 to 83. And that's what I do. I have my range set from 70 to 120. I correct at 70, I correct at 120. The rest of the time, I'm not worrying about it. I mentioned at the beginning, I've been leading pregnancy groups. We originally started our first group on Yahoo Groups, and I started moderating back in 2006 when I was pregnant with my second baby. And I also now lead a group for low-carb pregnancies called Group Pregnancies. And I just wanted to emphasize the difference in the outcomes between these two groups. The difference is breathtaking. I cannot tell you the difference. If you were to go into the mainstream group, especially large mainstream groups, there's a really big mainstream type 1 and pregnancy group on Facebook. If you go in there, it can be depressing. It can suck the breath right out of your chest. You're seeing those little cherub babies. A lot of them have feeding tubes. A lot of them are on ventilators. They're in the NICU for weeks at a time. They're taken extremely early due to complications like preeclampsia or placental failure. It's just a really sad state of affairs because all of those things are preventable. And when you look at the low-carb group, we're seeing healthy babies. We're seeing full-term pregnancies with normal weight and no complications. And personally, my low-carb baby was my healthiest. And he didn't have any problems with growth or brain development. He's one of the brightest kids I know, and he's close to tallest in his class. Low carb during pregnancy did not hurt him in any way. So we don't have the studies we need. We need peer-reviewed evidence base. And this doesn't exist because no one wants to experiment on a pregnant woman. It wouldn't be ethical. But what if we had women who are already eating low carb? And what if we could measure their outcomes? That's my hope. So if you'd like more details, please read my book, GRP Pregnancies, How to Have a Healthy Pregnancy and Normal Blood Sugars with Type 1 Diabetes. It's available on Amazon. It's available on every book-selling retailer online internationally. And to close, I would just like to again quote my hero in Type 1 in pregnancy, Dr. Lois Jovanovich Peterson. She said, when normal glycemia is achieved before pregnancy and moment-to-moment blood glucose control is sustained up to the time of delivery, the infant has the same chance to be normal as those infants born to a non-diabetic mother. Thank you.